one of the sessions.
This meeting is being recorded.
Organized by PHA. I'm very delighted to introduce our today's speaker, and he's none other than Dr. Saidur Rahman. He's a consultant in acute medicine and stroke medicine in Tarrant Valley Hospital in UK. And also he's our co-lead for Faculty of Neurology and Stroke of PHA. Let me introduce our today's distinguished panel of experts. We have got Professor Abdullah Al-Shafi Mojumdar today. He's a professor of cardiology and he's an ex-director of NICBD in Dhaka, Bangladesh. We have got Professor Mohsin Hossein. He's a professor of cardiology and also he's a head of Department of Electrophysiology of NICBD, Dhaka, Bangladesh. We have got Dr. Jun Cheong. I hope I am pronouncing it correctly. And he is a consultant cardiologist and cardiac imaging in Tarrant Valley Hospital, UK. We have had Professor Mohammad Bodrul Alam. He's a professor of neurology and also joint director of NINS, which is National Institute of Neuroscience in Dhaka, Bangladesh. We have got Professor Sharifuddin Khan. He's a professor of neurology and also interventional neurologist, currently working at NINS, Dhaka, Bangladesh. And also, the last but not the least, we have got Dr. Saziye Sanvardi. He is our consultant neuroradiologist, currently working in Tarrant Valley Hospital in UK. My heartfelt gratitude to our speaker and also our panel of experts and also our lovely audience who have taken all the trouble to join us today in our today's session. Before starting off our session, I would like to share some of our housekeeping rules. You can drop any questions, any queries, anything in our chat box. I'll be looking into the chat box, and I'm hoping that we'll have wonderful discussion at the end of our sessions. And now, with the permission of all our panel of experts, I'd like to hand over the mic to Saidur Rahman.
Thanks, Nadia. Thank you very much. And really appreciate you taking time to organize these sessions as always. And I'm also quite grateful to all of you who have sort of at such a short notice agreed to participate in this webinar. Nadia has sort of quickly sort of told you about what I do and what my role is. So my prime specialty is acute medicine, but I've been working in stroke medicine for the last 3 to 4 years. And I've been working as a consultant in stroke medicine in Tarrant Valley Hospital since 2019. I also work as an honorary clinical lecturer for Kent and Medway Medical School, and I am also involved with the King's College Medical School as well. So can you see the slides moving? Just give me a thumbs up if it is.
These are moving.
Perfect. Right. So the topic of today's session is embolic stroke of undetermined source. And this is an area that I'm quite interested in. It's primarily because this entity can actually cause a lot of morbidity and mortality to our patients. And if not investigated in the right manner, and if we don't treat this sort of patients in the right way, the outcome can be quite poor. So disclaimers, no conflict of interest, but I do have a hidden agenda here. I would like more and more people to be interested in stroke medicine and take up stroke medicine as their specialty so that we can serve our patients better. Now, a quick rundown of what we are sort of trying to be talking about today. It essentially is embolic stroke, and embolic stroke, what we call this embolic stroke of undetermined source. We're going to go into some of its etiological entities that we have to, in order to identify and treat our patients properly, we have to go into and look into thoroughly. And at the end, we will also try and talk about some of the treatment options. I may digress slightly along the way we go, depending on how the talk goes. So, as we all know that stroke can be a quite menacing problem for our patients. it's no surprise that with stroke, the patients can become quite disabled, and going down the line, the mortality and morbidity can be quite severe. All of us, we know that every minute there are about 1.9 million neurons that dies, and we lose about 12 kilometers length of myelinated neuron fibers. So time is money. That's why we have all those sort of different acronyms of FAST when we try and identify our patients. And particularly, embolic stroke can be quite devastating, because by the very nature of it, it can actually affect a huge portion of the brain parenchyma, causing marked disability. So I've put up some diffusion weighted imaging here just to sort of give you a flavor of what we'll be talking about. Obviously, we can see that there are certain of these images shows a potential embolic infarcts, and some of them may not be embolic in nature. And we'll try and sort of demystify some of these imaging mysteries later on. So it all boils down to the fact that when do we call a certain stroke, ischemic stroke, to be embolic? I'm sure all of you know that we have very many different criteria or classifications of ischemic stroke. My personal favorite, though, is the Oxford or the Bamford classification, mainly because it sort of primes you from very upfront to think about whether the stroke, what's the nature of the stroke or the underlying etiology in its functional status. And it talks about the vascular territory. And based on that, you can sort of from very early on try and guide the way you are going to investigate these patients. As you can see in this diagram on the right, we're talking about the central nervous system vascular supply. We all know that there is anterior circulation, there's posterior circulation, and we also have these perforating arteries. And just for a quick recap of the vascular supply, the anterior circulation is obviously supplied by the two common carotids, which then divides into the internal carotid going into the cranium, and then divides into its terminal branches of middle cerebral artery and anterior cerebral artery. And from the posterior circulation, you have the vertebrobasilar system. Both these vertebral arteries, they arise from the subclavian arteries. We do have at times variation where the vertebral artery can arise from the arch of the aorta itself. And then it goes inside the joint, forming the basilar artery, and then it divides into the two posterior cerebral arteries. And from these arteries, we also have some small, very hairline branches, what we call the perforating arteries. Now, based on which of these arteries are involved, you get different clinical stroke syndrome, and that's what the Oxford classification sort of identifies. So we call a ischemic stroke syndrome like total anterior circulation stroke based on what sort of functional disability they have, whether it's purely a motor symptom or purely a mixture of motor and sensory, and whether their higher cerebral function is affected or not, whether their visual field is affected or not. So based on those clinical findings, we can, from upfront, we can sort of classify what sort of vascular territory is involved. And in my mind and in my practice, what I normally do is I try to think of all ischemic strokes, if they're not lacunar strokes, to be a potential embolic stroke in its nature. Because if you have that approach up front, then there's less chance of us missing out of a potential source. And it's not in literature or in textbook, but I call this the rule of 20, because in my observation and in some literature, you'll see that 20% of all your ischemic strokes can be embolic. And out of these possible embolic stroke, around 20% or slightly more than 20% can be related to paroxysmal atrial fibrillation. 20% of all lacunar stroke can also have coexisting paroxysmal atrial fibrillation. later we'll discuss about why that is, because these patients may share common pathophysiological factors. And embolic stroke, it normally we in our clinical practice will see that there are the high NIHSS score strokes. And I'm sure you are all aware what NIHSS is. It's the modified neurological examination where we give certain scores to our patient in order to identify the burden of the disease itself in terms of their neurological deficits. And embolic strokes can cause more death and disability, as all of you will agree. At times, it can be quite straightforward to investigate these patients, but at times they can be quite challenging. I'm quite glad that it at times can be difficult. Otherwise, we'll all be obsolete because of Dr. Google. It's taking over our job. So moving forward, this is a very, very sort of basic sort of schematic presentation of what we look at in terms of investigating embolic stroke. So you have atheroembolic strokes, you have cardioembolic strokes, and also thrombus that can form in situ. And common things being common, we'll look into these factors first, and this sort of underlying etiological factors that we can sort of quite often we can easily identify. So for atheroembolic stroke, we have to look for carotid and vertebrobasilar atherosclerotic disease. Cervical and vertebrobasilar dissection is another quite common cause of atheroembolic stroke in the Western countries. I'll be quite interested to listen to my expert panelist opinion how common it is or how commonly it's seen in areas like Bangladesh. For cardioembolic stroke, atrial fibrillation is the cause. You may be very lucky to find someone who comes in with a stroke and already in AF, and that's easy peasy. But if it's not, then it can be quite tricky at times to identify atrial fibrillation down the line. And in situ thrombus formation, we all know about arterial and venous infarct secondary to hypercoagulability, whether that's secondary to antiphospholipid syndrome, polycythemia, and thrombocytosis. But this is, again, another cause of embolic or embolic-looking stroke. Now, I think as a neurologist or vascular neurologist or stroke consultant, we take pride to sort of answer those three questions, right? So the common training in neurology is where is the lesion, what is the lesion, and the nature of it. Most often or not, we can actually identify the clinical stroke syndrome, but at times, if it's a very small focus of cortical infarct, it can be quite difficult because they can present with a pure motor or sensory symptom. And you would be thinking that this could be a lacunar syndrome or lacunar stroke, but you'll be surprised when you do a brain imaging, it can at times show a very small foci of cortical infarcts. Looking at these two diffusion-weighted images, the one on the right-hand side, you can see a very classical lacunar infarct in the thalamic region, where on the left, you can see a very small cortical infarct in right about the hand knob area. And both of them can almost produce identical symptoms. So neuroimaging can guide us to identify some of these small lacunars, small cortical infarcts, which otherwise can be quite difficult at times. And I'm sure you all will recognize that our patient population, they're multimorbid. They have a lot of different vascular risk factors. They're quite elderly at times. So when you look at their, and particularly the one that we do, the non-contrast CT head up front, there's a lot of background activity. Brain atrophy. So finding out these small, subtle changes at times can be quite difficult. Now, as I said, cortical infarcts are, unless proven otherwise, they are embolic in nature. And small cortical infarcts can be quite difficult to identify. So all the stroke units or departments who deal with patients with stroke, they should have dedicated stroke protocol MRI scans, which should include at least a diffusion weighted imaging, ADC map, flare sequences, and gradient echo. Gradient echo is quite important because this is our blood sequence. And a lot of times, some of the larger infarcts can have hemorrhagic transformation within it, which can be at times difficult to pick up on a non-contrast CT. But we'll be surprised that when we do a gradient echo that can actually show a significant hemorrhagic transformation that can at times make us second think of our option, what sort of antiplatelet therapy we would put our patients on. And also at times we may have to delay putting our patients on anticoagulant because there is a significant amount of hemorrhagic transformation seen on the gradient echo images. Not only that, these MRI scans can also give us clue of the underlying etiology. So let's look at some of these images. This is one of my patients that I've seen last year. And he was a 78-year-old chap. The only known comorbidity that he had was hypertension, and he came in with right hemispheric stroke syndrome. So with these images, the lower two, the bottom two, this was his first presentation. And you have the diffusion weighted images, and also you have the flare sequence there. You can see that there's a fairly large subcortical hyperintensity. That was an infarct, but because of the location of the size, it looked more like an embolic infarct rather than a lacunar stroke. Later on, we'll go into some more details about when and why we call a certain lesion most likely to be lacunar. Now, this patient was randomized into a large randomized controlled trial. We call it's ATTEST-2, where we are sort of comparing alteplase with tenecteplase in terms of the efficacy of each of these for thrombolysis. But anyway, he made quite good recovery, but then he came in with another larger infarct. The two images on the top is from the second episode. You can clearly see that in the second episode, his insular cortex is gone, and it's fairly sizable infarct. Now, looking at those two images, he has two embolic looking infarcts, and both on the right cerebral hemisphere. And these are anterior circulation stroke. So immediately your mind will go into a stage where you'll think that, well, probably this patient has a carotid disease. Why would otherwise he would keep on having embolic looking stroke in the anterior circulation? And sure enough, when we did the CT angiogram, the image on the left where you have an asterisk, you can see, and I'm sort of putting my cursor down there, there's a quite tight stenosis. You can just barely see the lumen going up. So there was about a 90% stenosis, internal carotid stenosis on the right-hand side. And subsequently, when we re-imaged the patient, that stenosed segment was completely occluded. You can see upstream, where on the left-hand side, you can see the internal carotid artery going up. But the image on the right, you can see that it's sort of fully obliterated. Unfortunately, this patient did not go down to have a carotid intervention because second time around, the vessel was fully occluded. But the point I'm trying to make is that if you're having anterior circulation stroke and they are recurrent on the same side, same cerebral hemisphere, you should go back and have a look at the images carefully, whether there is a significant stenosis of the carotid arteries on that particular side or ipsilateral side. Sometimes it can sort of give us some red herring and throw us off our track. So in this image, the image on the left, extreme left, you can see that with the arrow, it's a posterior circulation infarct where you have medial temporal lobe and part of the right occipital lobe involved. And all of us working in stroke medicine or neurology, we know that if this has to be a disease, or if this has to be an infarct secondary to atherosclerotic disease, it has to be the vertebral artery or basilar artery involvement. But at times, because of anatomical variation of the intracranial arteries, you can have a posteriorly or posterior circulation like stroke from an anterior circulation. And in this particular case, the image on the right actually shows that this patient had a fetal type PCA, which essentially what happened, the right internal carotid artery went inside, and then it sort of continued, it given off the middle cerebral artery, but continued as the posterior cerebral artery, which normally would come off the basilar artery. So there was a significant stenosis in this patient downstream in the internal carotid artery, but because the posterior cerebral artery in this case has come off the internal carotid artery, the thrombus, atherothrombus, has gone into the occipital lobe rather than in the other usual anterior circulation territories. Similarly, you can have other variation, like you can have fetal type trigeminal artery, where anterior circulation can give posterior circulation looking infarct. So we need to be mindful of this variation, because otherwise, if this patient had a negative report for no atherosclerosis in the vertebro-basilar system, we would be going to hunt for things like atrial fibrillation. But the fact that this patient has a fetal type PCA is actually giving you the answer. Now, it's slightly more trickier when it comes to the subcortical infarcts, because the location of the infarcts and the orientation of it, the size of it, will give you the understanding whether this can be a lacunar stroke or a non-lacunar stroke. So by definition, a lacunar infarct or lacunar stroke will be a subcortical in nature, or the deep gray matter, and they will have to be 15 millimeter or less in diameter. Now, at times, this simple definition doesn't give you the answer. So you have to look into the other features in that patient, their clinical presentation, and also the radiological features that will give you a clue. So let's have a look into some of these various presentation that you can have. So just recapping a bit about the perforating arteries. The perforating arteries, these are hairline arteries, and they can be affected with hyalinosclerosis because of various vascular risk factors like hypertension and diabetes and hyperlipidemia. And they can get clogged up pretty easily, giving rise to the lacunar infarcts. And mostly these perforating arteries, some of them come from the middle cerebral artery. Some of them can come from the terminal internal carotid artery. And then you also have some perforating arteries coming from the posterior cerebral artery and the basilar artery. Now, some of these subcortical infarcts can actually be due to embolic stroke blocking a chunk of or a series of perforating arteries. So we have to differentiate between things like the striatocapsular infarcts from the lenticular striate infarcts. In terms of the striatocapsular infarct, the image on the top, you can see that the entirety of the basal ganglia, they're involved. So the head of the caudate nucleus, the globus pallidus and putamen, they're all involved. And the reason it is that these lateral lenticular striate branches that come from the middle cerebral artery, if they get partially or completely blocked by a large thrombus, then the whole area of that basal ganglia, including the caudate nucleus, the lentiform nucleus, and globus pallidus, and also the anterior internal capsule, will be infarcted. but because it's a partial occlusion, the distal circulation remains patent. That's why you're not getting any cortical infarcts in this case. So although these are involvement of the basal ganglia, and this large portion, this particular variety will alert you that most likely this is because of an embolic stroke. The one at the bottom where you have this classical infarcts, they are from a single occlusion of one of the lenticular striate branches, and they would not have the classical presentation or distribution where what you see in the stratocapsular infarct. The multifocality and bilaterality of the infarcts, if they are present simultaneously, again gives rise to the suspicion of embolic shower, and this is the same patient where you have scattered areas of subcortical infarcts in both cerebral hemisphere, and this is some of the classical presentation that we see in patients with embolic shower and possible cardioembolic stroke. Again, simultaneous presence of both cortical and subcortical infarcts is another indication that the underlying etiology could be embolic in nature. Watershed infarcts, I find it quite interesting because a lot of time we get called from our IT colleagues, and the reason being that they were admitted in ITU, profoundly unstable hemodynamically, they're not waking up, and they end up getting an MRI scan, and then you see something like that, the top image. So you get a series of small volume infarcts. And I'm sure you're aware that these are sort of almost a classical presentation of watershed infarcts, where you have two different vascular zones. They're sort of meeting in the middle, and the tissue there is quite vulnerable because due to a lack of relatively good blood flow. And it's classically called the string of pearls appearance. But there are at times when you can have this similar appearance, and that's due to embolic shower. So the image on the top is what we call an internal watershed area. And they're mostly because of hemodynamic instability, profound hypotension. But the image on the bottom, which is the external watershed area, which is the borderline between the ACA, MCA, and PCA, they are most likely due to an unstable plaque or a stenosis artery downstream. So just because someone has a watershed infarct doesn't really mean that it always has to be because of hemodynamic instability. It can be because of an embolic shower. So we need to be mindful and review the images carefully. So now we have all become a bit of an expert of imaging, and we have decided that a certain patient with their radiological and clinical findings most likely have an embolic looking stroke. What do we do next? So common things common, and we need to do the basics right. So a 12-lead ECG, and even before that, you should just put your fingers on the pulse, because you just may be lucky that you found an irregular pulse, you've done an ECG, and voila, you've got your atrial fibrillation. And the number of times I actually go into the ward looking after a patient, I find patients in AF is staggering. So it's a common good practice that helps you out. We will obviously do carotid imaging. Now, whether that should be a CT carotid angiogram or a carotid Doppler, that depends on various things. So if the imaging shows it's purely anterior circulation, then you can just go and do a carotid Doppler. If the patient cannot have, for some reason, a contrast imaging, like if they have renal failure, then you don't have any other option. You have to go for a Doppler studies. But essentially, when you find that there's a significant disease in the anterior circulation, whether you identify that with a Doppler or an angiogram, invariably you'll repeat the other modality of the investigation, because each of these gives you a slightly different information. So the Doppler will tell you the hemodynamic nature of the stenosis itself, where the CT angiogram will help you plan the intervention, because it will tell you whether this is a mixed atheroma, whether it's heavily calcified atheroma, and the location of the arteries, whether this is approachable for the vascular surgeons to do an endarterectomy. In the right context, you may need to do things like MR or CT venogram to identify venous infarcts or venous sinus thrombosis in the right context. If it's a young patient without any known vascular risk factors, here where it gets a bit woolly, because young stroke, in terms of their age definition, it's not set in stone. So some will consider young as young as 50 years old, and some will say it's 55. In our own trust, we take the age of 55 as a cutoff. So in this sort of patients, if they don't have any raging or multiple vascular risk factors, we would investigate them for thrombophilia, and it's mostly things like antiphospholipid syndrome. And I will be quite interested to find out from our neurologist from Bangladesh what's their experience in young stroke patients, and how many of them, or what percentage of them actually turns out to be antiphospholipid syndrome. The other thing that we would also look for is patent foramen ovale. In Western countries and places like UK, because venous thromboembolism is quite rampant, this paradoxical embolization and causing infarct it's quite a significant thing. So bubble echocardiogram is a almost mandatory investigation for our young stroke population. Now, there's a slight difference between ESAS and cryptogenic stroke. We tend not to use that terminology anymore, cryptogenic, because it essentially says that you haven't done the investigation fully, or there are more than one etiological factor that you think is in play. So we would only call, so we tend to avoid cryptogenic, the terminology of cryptogenic stroke, and we use embolic stroke of undetermined source more readily. And that's the sort of drive that's been going on in US and in UK and Europe. So once you have investigated for the usual cause, you've done the right imaging, you've done the right vascular scans as well, you've gone through the thrombophilia screen and all the bubble echoes, and you have exhausted the possibility of the underlying etiology. Then comes the terminology of embolic stroke of undetermined source. Now, again, in that group of patients, there are certain things that's quite important. So paroxysmal atrial fibrillation still is the number one reason of embolic stroke of undetermined source, because it can be quite treacherous and it can be very, very difficult to identify. The other entity that's coming up as potentially a major etiological factor for this sort of patients is ICAD, or intracranial atherosclerotic disease. And non-stenotic carotid or vertebro-basilar atherosclerosis is another factor. Aortic arch atheroma is one of them. Seronegative antiphospholipid syndrome, that's something that I've sort of come across a few times, and there's a lot of emphasis on this entity nowadays, where you'll have persistently negative antibody test for patients who otherwise phenotypically looks like a barn door antiphospholipid syndrome, but they just don't test positive for the antibodies. And then you have things like LV aneurysm, LV thrombus, and sometimes rare causes like atrial myxoma. So I'm going to talk about paroxysmal atrial fibrillation. This is something that I'm heavily involved in, and I think it's important that we figure out a way to investigate this patient. So why is it so difficult? I'll tell you a small story of one of my patients. So she was 69-year-old, and she came in with a very classical embolic looking infarct with her imaging and everything. So we started off by doing a 24-hour tape, which was negative, then moved on to a 7-day event recorder, which was negative, and ended up inserting an implantable loop recorder that I'm sure all of us will agree that's the gold standard to investigate for this sort of patients where we have a high degree of suspicion of paroxysmal atrial fibrillation. So that patient had the ILR for 3 years, nothing, nada, did not pick up anything. And 3 years down the line, first week, she ends up coming to the hospital with a chest infection, and she had a 12-lead ECG showing fast atrial fibrillation with fast ventricular rate. So that's how elusive PAF can be. So just because you've put in an ILR doesn't mean that you can actually pick off PAF. So, but with the landmark trials, we know the longer we investigate or interrogate the heart, the greater is the yield to identify PAF. The landmark trials like Embrace AF and Crystal AF, they've all established that. But putting in an implantable loop recorder and monitoring it for that duration, it doesn't come cheap. It costs about £12,000 per patient, and that comes from a sort of economic analysis from National Institute of Clinical Excellence, or NICE, who's one of our guideline providing bodies in UK. So what do? We need to find out something in the middle. We can't be dishing out £12,000 for all of our patients. So in my trust, we embarked on a quality improvement project. What we did, we looked at patients who had possibly embolic stroke, and we analyzed the data and tried to figure out what was the outcome or what was the yield of identifying PAF. And we compared it with the gold standard of implantable loop recorder. So from that quality improvement project and from that data analysis, there were certain quite interesting things that came up. And one of these was that a lot of these patients actually did not need to be investigated for that duration of time, because they actually had quite burned or lacunar infarcts. So we actually requested for implantable loop recorders for these sort of patients, which I personally think it's wrong. And another 28% of patients actually had significant carotid or vertebrobasilar stenosis that could have perfectly explained their clinical stroke syndrome. But these were not reported correctly up front. And during our analysis, when we went back and took the help of our neuroradiologists, they actually had identified those cases. And we also saw that 7% of patients, which ended up having 24-hour tapes and various length of halters, if we were a bit more diligent in their old records, old ECGs and previous halters, they actually had identified PAF. So what it showed us that we need to be very, very thorough in looking through old records, looking through images, taking that extra step, going and having a discussion with our neuroradiologists to make sure that we're not missing out on a potential etiological factor in a significant stenosis before we embark on investigating this patient. So we came up with a pathway, and we decided that we would use a newer device which is an adhesive cardiac patch, which is a single lead ECG or cardiac monitor that records the rhythm for 14 days and analyzes it through artificial intelligence algorithm, and then notifies us directly if that patient has been identified with either PAF or any other malignant arrhythmias. So we've been using that for last year or so, and we've just done another set of data analysis. And in comparison to the halters, where the pickup rate of PAF was less than 2%, 1.79 exactly. This single lead adhesive cardiac patch has picked up AF in 8.6% cases. And the waiting time from request to report for the halters was about 103 days versus only 14 days for this newer adhesive patch. And 100% conversion rate for anticoagulation. So all in all, this has proven to be a very, very significant intervention in investigating this sort of patient. And we as a trust, and me personally, I'm now working with NICE to evaluate this technology and coming up with a guidance. And hopefully by May this year, this will be in practice across UK. Now, one of the things is important, the ILR still remains as a gold standard, but there are certain papers that coming up recently, which actually shows that beyond the initial 2 to 4 weeks, the pickup rate of atrial fibrillation, even with implantable loop recorders, drops quite dramatically. So whether in future, we don't need to do implantable loop recorders, and we can actually do, say, a 14-day or 28-day single lead cardiac adhesive patch monitoring, whether that should be enough, that remains to be seen. And our cardiology colleagues, they've been absolutely brilliant. So they've been working with us quite closely. And now we have a very dedicated pathway to decide which patient goes on to have an implantable loop recorder if they're negative for the cardiac adhesive patch. And we try and stick to that. Moving on, I think this is a beast. Intracranial atherosclerotic disease. It's an entity that's lesser known, but it can be quite significant challenge. It can be a significant challenge in terms of diagnosis and also management as well. And later on, I'll be very interested to hear from Professor Sharifuddin what his experience is with intracranial atherosclerosis, because it can pose a lot of challenge when the interventional neuroradiologist or the interventional radiologist doing thrombectomies. Again, it's more important or more pertinent in patients in areas like Bangladesh and Southeast Asia, because various trials have identified that ICAD is more common in that in Asian ancestry patients. And also it's important because there's a higher recurrence risk. So what is ICAD? It's essentially an atherosclerotic stenosis or atherosclerotic disease of the terminal internal carotid artery and the middle cerebral artery, also posterior cerebral artery. Interesting thing, going back, people can have ICAD without involvement of the extracranial internal carotid arteries or carotid disease. So it can just be there as a single entity, and it can be easily missed at times. So these two images, they're showing the terminal portion, the one on the left, the terminal ICA, where you can see there's heavy calcification. That's a classical ICAD. So there are few areas where we are learning. We know now what to do with ICADs which are symptomatic. So if you have investigated the patient thoroughly and the patient has a significant stenosis of intracranial carotid artery or the middle cerebral artery, and the infarct is on that side, then you know most likely ICAD is the culprit. And in this sort of patients, we tend to do dual antiplatelet therapy with intensive lipid-lowering therapy for any duration of 3 weeks to 3 months. And the newer guidelines from the European Vascular Surgeons Association and also European Stroke Organization, they are sort of recommending 3 months duration of dual antiplatelet. But we don't really know what we need to do with the asymptomatic ICADs. There was a trial called SAMPRIS where they compared the best medical therapy, or BMT, which was dual antiplatelet intensive statin lowering statin therapy with 80 milligrams of atorvastatin and tight control of blood pressure with a target blood pressure target of 130 or 80 or below. And it has shown that the intracranial stenting did not come out on top. So as it stands now, we don't have a clear indication to do stenting for these patients. And if they're asymptomatic, whether you actually provide them with antiplatelet therapy or not, that again, a question that needs to be answered. Identifying or quantifying the stenosis can be a bit of a challenge. And I was discussing with Dr. Stanvardi the other day that the formula that we use to quantify extracranial stenosis, like in the internal carotid artery, you either use the Nassett criteria or ECST criteria. You can't use that for intracranial stenosis because these vasculature, they taper off, and the caliber of the vessel, they get reduced. So it's, as it stands, we don't have a definitive formula to identify or quantify this stenosis. It's more of a visual impression. And later on, probably Dr. Stanvardi can shed some light on that technique. And as I said, I'll be very interested to know from Professor Sharifuddin what sort of challenges he faces when he does thrombectomy in these sort of cases. Transcranial Doppler at times can give you a bit of a clue, because if it shows or identifies microemboli, that's again an indication that these are the culprit lesions rather than anything else. Non-stenotic stenotic carotid atherosclerotic plaque, again, there are quite a few trials that shown that even if the stenosis is less than 50%, doesn't mean that they're innocent. They can still be the underlying cause for that embolic looking stroke. Sure enough, we don't send them for endarterectomy, but because all the trials with the Nassett and the ECST, the cutoff that they went for is 50% or more. And the latest guidelines for ESVS, again, it has to be more than 50%. But trials have shown that even lesions less than 50%, they have a more concordance with ipsilateral infarcts. As you see these numbers from the CAPIAS trial, it's about 31%, which is no mean number. It's quite a high number, and it's unlikely that this is a chance finding. And in these cases, although we're not sure whether they will be in future, they will be amenable for endarterectomy, whether they will be amenable for stenting, but it needs more randomized controlled trial. But we now know that there are certain features that makes them more prone, or they make them more high risk to cause embolic strokes. And these are things like plaque ulceration, predominantly soft plaques or hemorrhage within the plaque. And if you see a superadded thrombus, that again gives you a very high degree of suspicion. But this now has not been translated into anything into our clinical practice yet. But more and more people are trying to sort of design new trials to investigate this. And I'm sure in the next few years' time, we'll see a change in our practice. So again, just quickly go through these patients. Again, I think at the beginning of my talk, I said that a lot of these risk factors, they have an interplay. So the same thing that causes carotid atherosclerotic disease, things like hypertension or diabetes or hyperlipidemia, there are individual risk factors for ischemic heart disease as well. And they can have a big influence in how the heart is remodeled. So they are risk factors for atrial fibrillation. So do you just stop when you see a stenotic plaque and you know that this is the cause of the infarct? Do you stop there? You don't do any further investigations for PAF? Again, that's $1 million question. And I think the jury is out, and there are certain variation in our practices. Some may say, well, I know this patient has a stenosis and this patient is going to go for endarterectomy, but I would still like to do a minimal duration of cardiac rhythm monitoring for PAV because the same risk factors, this patient is also a high risk patient who may have underlying atrial fibrillation. This is just a few images where it shows the various stages of the atherosclerotic plaque. The image on the right, you can see from the top, there's eccentric looking calcified plaque. The one in the middle here, you can see there's some irregularities there near the lumen and a lot of soft plaque, but this irregularity at times can signify plaque ulceration and tells you that this plaque can be quite high risk. Moving on, I think this is another area where we have been underplaying it a lot. It first came into light with a autopsy trial where they analyzed 500 cases, and they found out that this patient had recurrent infarcts and they had quite significant atherosclerotic plaques in the aortic arch. And from this French study, it's called French Study of Aortic Plaque in stroke group, they have identified that 11.9% of recurrent infarct patients actually had a plaque thickness of 4 millimeters or more. And more, we know that this is a real underlying factor. And Ascot classification, it gives you a causality of these atherosclerotic plaques with embolic looking stroke. So if you have a plaque thickness of 4 millimeter or more with a mobile thrombus, attached thrombus to it, it's highly likely that this is the cause of the stroke. If there's no attached thrombus, but it still is more than 4 millimeter, then again, it's a likely possibility. But if it's less than 4, without any of the other high-risk features, then it's less likely. And usually when we do carotid angiograms, the protocol includes the aortic arch as well. So you don't need to do a dedicated imaging to identify aortic arch atheroma. You can just go back and look at those images, sit down with your neuroradiologist or your vascular radiologist and cast an eye on the scans to measure the atheroma and look for some of the high-risk features. But if needed, it can be picked up by transthoracic echo as well. Hopefully later, Professor Shafi Majumdar and Jun Chong can sort of talk about some of these echo modalities, mainly in PFO and maybe in aortic arch atheroma as well. We don't anticoagulate this patient. Dual antiplatelet can be an option, but as it stands now, there is no high quality RCT which mandates us to use dual antiplatelet unless there's any other indication. There's a image for aortic arch atheroma. This is one of my patients. She was 55-year-old, presented with the embolic looking stroke. We've investigated her thoroughly, and the end result is that this patient had quite a significant aortic arch atheroma, about 5.4 millimeter. Dr. Sanvardi and myself, we looked through the images just the other day. Now coming to patent from anomaly, it will be quite interesting because we here in UK and some of the other Western countries and even in US, as I said, that VTE is a big thing. So that automatically makes paradoxical embolization as a potential cause for embolic stroke of undetermined source. Not too sure how it is in Bangladesh, because I've graduated in 2004, and the first 10 years of practice in Bangladesh, and I don't really recall seeing a single patient who actually had a stroke, embolic looking stroke, and we had identified the underlying cause as PFO. Whether that is a practice, that's something that we do in Bangladesh, quite keen to know. But common sense says that probably it's not, because VT is not a big thing, but it is for our patients. The European Stroke Organization is still working on their criteria when to refer the patients for investigation and subsequent PFO closure. But the Americans, they've already made up their mind. So they say, the American Stroke Organization recommendation says that if the patient is between the age of 18 and 60 and they have an embolic looking stroke, and we have identified a PFO, exhausted all the resources to look for other possibilities, and if the PFO have high risk features, then this is an indication to do a PFO closure. And there have been few recent trials. One is an extension of the previous trial of RESPECT, and a couple of other trials, one in New Zealand, I'm not sure where the other one is, that's close and reduce. And all of these trials have shown significant benefit with PFO closure. And one interesting thing that came up in these trials, that the longer the duration of follow-up, the better was the outcome. So in these three trials, the mean of each of these trial follow-up is about 3.5 to 4 years. So the benefit of PFO closure is rather long-term than short-term. This is a video. I'm just gonna skip through this. I think later on we'll hear from Professor Shafi Mujumdar and June about PFO and what they think about what should be the modality of imaging. Left ventricular thrombus, it's there. It is a cause, and I think in my practice and in my experience, it's more to do with the LV thrombosis in patients with ischemic heart disease and recent MIs rather than dilated cardiomyopathy. And I've looked through some literature, and they all suggest that. Maybe I can be proven or corrected later on. But in case of dilated cardiomyopathy, there are certain high-risk features in the cardiac MRI that can sort of give us some heads up that these patients can be high risk for developing LV thrombus down the line. Transthoracic echo, I think it's the first choice. I say I think because every time I asked June this question, he said transthoracic echo, but contrast enhanced transthoracic echo, I know that it doubles the sensitivity, and we've done few of those for our patients. And this is something purely that I've read up on certain literature, that late gadolinium enhancement CMR is probably the best modality because it can differentiate between the non-vascular thrombotic material from the myocardial wall. Few images where the late gadolinium enhancing CMR is picking up a thrombus in the bottom image where the transthoracic echo or the bubble echo couldn't. Right, I'll put you out of your misery. So it's almost the end. So this is my 2-penny word. So we have to be quite sort of aggressive and quite vigilant in investigating for the underlying etiology, because if we don't do that, then you are not preventing a stroke recurrence. It will happen. It will come back and bite us. The differentiation of lacunar from non-lacunar infarct is critical. And I think at times it can be quite difficult. So we need to have a quite good relationship, working relationship and trust with our neuroimaging colleagues so that we can go back again and again and discuss these cases. We learn from them and we identify which are the high risk patients, and then we embark on this journey, because as you found out, it can be quite expensive trip. I think 24-hour tapes and 7-day event recorders are a waste of our time and money. And it's not only me, trials after trials have said that. So it's time to adopt new technology. As I said, ILR is still the gold standard, but even in UK and US may be slightly different because the insurance pays for that. But even for us, National Health Services, it's free. So we cannot be dishing out ILR for everyone. So we have adopted new technology, and I'm sure in places like Bangladesh, it's valid as well. We need an MDT approach. We need a close working relationship with our radiology colleagues, cardiology colleagues, and neurology colleagues as well, because a lot of time we know about the stroke mimics and how difficult can they be at times. And we just need to keep on learning, because it's training. And Esa will tell you how many times I go and bug her to learn a bit more about neuroimaging, and it's fascinating. Thank you all. That's all I have to say for today.
Thank you so much for your brilliant presentation. I have learned a lot. Thank you so much again. Actually, it's not easy to get our head round. Professor Bultul Alam, sir, please.
Please, again the question. I'm not.
Okay.
What is the question?
So, what are the clinical parameters we should look for if we want to suspect embolic stroke? Dr. Rahman has mentioned about a high NIHS score, but is it always true? What about low NIHS score? Can they be embolic stroke?
Actually, in embolic stroke, both may be happen, but we always get the high NIHS score. But I think it is not fact, not true. It may happen in NIHS score either high or in low. And sometimes we see a patient that comes with us a embolic stroke that is not, there is not etiology. Actually, the patient is not suffering from any disease that can produce a stroke. That is the number one suspicion. Number two, sometimes the stroke happen in the area where the usual stroke happen. It is the area that is not happening usually, particularly in subcortical or cortical stroke where the arterial territory is not matching. Number three, in case of embolic stroke, sometimes we see the patient develop convulsion, and that is one of the important features for embolic stroke of cortical origin. So not only the NIHS score, there are many various features that can suggest that patient might have suffered from embolic stroke of undetermined origin.
Okay, that's interesting. So
Nadia, can I just moving on from what the Professor Alam has just said, I also want to add in that yes, it doesn't always have to be a high NIHSS, because in one of the slides I did mention that you can have a very small cortical infarct, and that gives you a very localized symptom. It may be in the hand knob, and the patient will have just
hand.
Yeah. So in those cases, you probably, from the clinical picture, you may think that it's not embolic, but the images will suggest that it is. And as I said, cortical infarcts, unless proven otherwise, they are embolic in origin, and you have to hunt for it.
Actually,
can I just?
I am also agree with Dr. Saidur that the cortical infarcts, particularly the radiologist colleague, can suspect, and the suspicion is very important. as because without radiology guiding, it is not possible for the clinician to delineate all the features of a stroke of undetermined origin. It is the radiologist that can suspect, yes, that might be the cause of embolic stroke of undetermined origin. Particularly in embolic stroke, we can see the radiology. Radiology is very important for to delineate a picture of embolic stroke.
Can I just share one thing?
Yes, sir, please.
In case of stroke, we always look for the vascular territory, and we divide the brain vessels in different segments for the sake of description as well as for the sake of getting proper topographical representation also. Suppose if you take a careful look, we can see majority of the ischemic stroke occur in the MCA territory, middle cerebral artery territory. And we divide middle cerebral artery territory in different segments, M1 segments, starting from the internal carotid to bifurcation, and M2 from bifurcation to Sylvian fissure, this way. But today's topic is where we got stroke from cortical or subcortical. It will be very much limited to particularly M4 or 5 region, giving less neurological symptom that Rahman said. It will be just numbness of the hand or numbness of the face or some kind of convulsion also, that Dr. Alam said. So in case of depicting stroke, it's better to keep in mind that vascular territory should always follow the principle. I think in that way, we can also make it summarize. And one more thing I just want to share with you. If you say 80% of the ischemic stroke, of them, 80% is middle cerebral artery territory. If you just go a retrospective look or a prospective look to your imaging, so far stroke you have encountered, you will see most of the strokes are MCA territory, middle cerebral artery territory. That is also another point to be noted. Thank you.
Professor Sharafuddin, may I ask you a quick question while on this topic?
Yeah.
So we talked about intracranial atherosclerosis, and yes, when I talk to my colleagues, interventional neuroradiologists, they often say that when you perform thrombectomy in these patients, at times they've seen that soon after pulling out the clot, there's a quick clot formation. And they're sort of looking into various options like low-dose intraarterial thrombolytics or certain other agents to prevent that. What's your experience in Bangladesh with these cases?
Yes, thank you. That's another interesting thing. Again, I divide the brain vessels in a large vessel, that is from the arch to the common carotid to carotid, medium size after division of middle cerebral artery, and small size that we call cortical or watershed region. So first and foremost thing is that once there is large vessel occlusion, atherosclerotic changes in the carotid, and there is a occlusion in the M1, it's sometimes it's very difficult to pass my device through that stenotic part. So it's matter of 5 to 10 minutes to pass a wire through that, and we just do the immediate carotid stenting as per NACET criteria, and then we pass our materials to the M1. It's in our territory window period time, we just pick up the M1 clot and just catch it up and draw it outside, aspirate, number one. Number two, sometimes it happens that distally M4 and M5 region, sometimes emboli are gone. So in that case, sometimes we use antithrombotic agents, that is ATP antithrombin 3, or sometimes we use altiplase shortly for that period. But after waiting for 5 to 10 minutes, when we go for a global check in angiogram, we see there is no clot, no burden. So we come across this way in this field, like that.
Thank you very much.
It's quite interesting. What do you usually do? Is it an altiplase, intravenous altiplase, or what
in fact, in our setup, our protocol is that anybody having stroke, that is cortical, subcortical, whatever it may be, we just immediately go for a thrombolysis by altiplase. We see the responses. If there is no response, then we immediately go for vascular imaging. That is, we do the 4-vessel angiogram in CTA or MRA in short protocol. By 10-15 minutes, they give us the report. Otherwise, once we think, yes, this is a large M1 occlusion and we need to go for mechanical thrombectomy, then we go straight for DSA, digital subtraction angiography. And there we do the 6-vessel angiogram, reading the brain vessels, calculating the collaterals, whether it will be helping, the collaterals will be helping to withdraw the other deficits. That is why after doing 6-vessel proper angiogram, then we proceed further.
Thank you.
How long
Yes,
it takes to complete all the process, because we have a time limit. It's a time sensitive
Yeah,
procedure.
yeah.
And how long it
Thrombectomy,
takes usually?
if everything was fine, it's a matter of 30 to 40 minutes. And the ASA and HA criteria has given the dot to needle time. We cannot follow in that particular time, but whenever in our cath lab, if the materials are ready, everything is working fine. Hardly 35 to 40 minutes, you can pull out the thrombus.
perfect.
Fantastic.
Essa, would you like to say something about the ICADs and the measurements of the stenosis?
Yeah, in ICAD, we grossly divided 2 categories, intracranial and extracranial. In Bangladesh, majority of the patient, 30 to 35% of the patient having diabetes. So they are having both macro and microvascular changes. Once we go for a vascular imaging by ultrasound or CT MRA, or we sometimes go for DSA, we can see there is also intracranial stenotic diseases more sometimes. So in that case, if it is medium-sized vessel, suppose supraclinoid or paraclinoid part of internal carotid artery, there is a significant stenosis, and that stenosis is showering emboli going to the distally. In that case, we calculate what are the collaterals. If it is adequately collateral, we go for extensive medical therapy that you have mentioned, double antiplatelet and anti-lipid lowering agents. And for a particular time, we wait whether any changes of the vessel caliber. And at one point, we go for vascular imaging, MRA. We see is there any calcification or any narrowing of the vessels. And finally, if it is not possible, then we go for stenting. Although intracranial stenting, a lot of companies are offering use stents in the market, but it's not routinely, rapidly done. What we do in case of extracranial carotid atherosclerotic, following the NACET criteria. But intracranially, we are a bit more conservative. We do not go harshly.
It will be interesting to hear from Essa about what you feel about the ICADs, Essa.
Yes. First of all, I would like to thank you, all the participants and the speakers. It was quite instructive for me again. Thank you. It's a bit difficult decision in terms of leading the clinician in the best way to me. The evaluation of the intracranial atherosclerosis, defining the significant stenosis indeed. As we have discussed before, and as you just mentioned, because of the anatomy, because of the tapering of the intracranial arteries, starting from petrous segment to the terminal ICA, it makes things a little bit more difficult. Regarding the literature, what is advised is that proportioning involved segment to the normal appearing petrous segment. However, speaking from my experience, I think it is not that easy and that straightforward, because we still need some functional data to support the imaging, either CT angiogram or MRA. Likewise, if you have knowledge of collaterals, or if you can get CT perfusion to understand what's going on together with CTA, you may make a better decision. So simply saying that, okay, there is some wall calcifications and significant or moderate stenosis, because given numbers, certain stenosis percentages is not easy in that area, and each modality has its own disadvantages. If I speak for CTA, it's not easy to distinguish heavily calcified walls from, let's say, within the cavernous segments, for example. It's not easy to differentiate the calcification itself from the adjacent bone, or to make judgment if there is intimal hyperplasia together with the wall calcifications here. Regarding MRI, okay, you see, you only have the luminal knowledge. You see the lumen is smaller than any segment, either the involved segment or the contralateral identical segment or to the proximal. However, in this case, you are being lack of knowledge what's going on in the of the wall. Either it is calcified or it is soft tissue plaque. Even the decalcifications are much more common than soft plaques, excuse me, in the intracranial atherosclerosis cases. So I think before saying something, a radiologist is better get all those data together to make the best judgment to me. For myself, while reporting, what is important is that just connecting the dots. If the findings topographically, the lesions I'm seeing are corresponding to the clinical symptoms, the neurological deficit, let's say, and then etiologically, if I can find relevant explanation, a causative lesion for that. At some point, as if you are working on neuroradiology, you stop chasing for normal anatomy, but you start chasing for hidden facts, hidden findings, like basilar artery fenestration, aberrant vasculature, origin of vertebral arteries, fetal or embryological, any circulation like variation, something. That's why good collaboration is the most important thing to me. And for ICAD, if it is possible, of course I would prefer CT angiogram at first line. But if it is possible, of course we are competing with time for such cases. If we have chance to get everything together, all possible imaging features findings to make the best judgment to me.
Thanks, Essa.
Thank you. We have got one question in a chat box. Is there any role of statin in case of embolic stroke? This one is for Professor Abdul Shafi Majumdar.
I'm not too sure whether Prof. Majumdar has actually heard you, Nadia.
Are you here? Professor Abdul Shafi Majumdar, please.
Right. While we're waiting for Prof. Majumdar to rejoin, I think I'll take this one. So the statins, they not only act as a lipid-lowering agent, they also have other functions. So they can work as a free radical scavenger, and it sort of improves the health of the vessel wall and also the intima. And I think the question is, why we are having this embolic stroke? So if this is from a atherosclerotic plaque, by all means, this patient will need a statin therapy. And if possible, we would go for high-dose statin therapy or intensive statin therapy up front. At times, it may be difficult to prescribe such high doses to our patients because they're elderly and they can end up having a lot of side effects from them and they can't tolerate it. But the answer to the question is yes, you would give statin therapy in most of your patients. Professor Majumdar has joined again. Sir, the question was to you is whether statin therapy...
I heard the question.
Brilliant.
I'm sorry I joined lately because today is my working day. Today is not holiday. So I have to come back to my house lately. The question was, the statins have any role in the embolic stroke? If I say straight away, if there is a embolic stroke, the clean-cut embolic stroke, there is no role in the for the management of the embolic stroke. Only in the atherosclerotic, if there is a evidence of the atherosclerosis, then we can use the statins. There is my simplified question answer the question.
Can I ask you a question, sir? It's
Yeah,
from my
yeah.
own understanding. So we've been talking about this entity of patent foramen valley and how it's an important factor for our young stroke patients in UK because of VTE. What's your experience in Bangladesh, and have you actually come across cases where you've seen a young patient with stroke with patent foramen valley?
Yeah. I was looking at your slides where you said about the PO4. Though it was not recognized very easily here, but there is some centers here where there is a subcutaneous procedure of the closing of the PO4 is done here. And there is some cases reported that the embolic stroke from the due to the PO4. It has been reported in and published in some literature in some journals. So a few cases. I think there is a lot of cases which is not recognized properly. Due to the constraint of our resources, we cannot go through the whole investigative procedures of a patient to find out the etiology of the stroke or and the making all the efforts to find out the etiology. So,
Thank you, sir.
But there is a report. There are reports.
June, do you want to say something about the modalities that we can use for identifying PFO and the high risk features of it?
Hi, I'm Jun Chan, the cardiologist. Thank you for inviting me. Great talk. Yeah, just kind of a few points really. You mentioned about like carotid stenosis and whether you need to identify them and kind of treat them. So I can tell you about in cardiology world, we know that 50% of our MIs is caused by obstructive coronary artery disease, i.e. less than 50% stenosis, and half of it is caused by significant or obstructive coronary artery disease. Because what we've come to understand is that it's a systemic disease rather than a focal stenosis. So fixing a focal stenosis doesn't really prevent the disease occurring. So it's more of a indicator that is plaque burden. So we kind of, our stable disease patients, we don't stent them anymore, even if it's 95% stenosis. Okay, so that's kind of one thing. The second thing is about, you mentioned about aortic arch disease, whether you want to kind of screen for them. Again, I think it's probably not necessary because what you're going to do about them is statin. Yeah, your treatment is statin. So your patients who's got aortic arch calcification or ulcers and things like that would be your elderly patients over 60s, and you put them on statin. So knowing whether there's disease in the arch, it's not going to help you to change your management. That's what I would say.
Beg to differ slightly, June. The whole idea of identifying the aortic arch atheroma with the thickness is when do you stop to hunt for those other elusive causes? Because say if you've done a 14-day cardiac monitoring and that came back as negative, you've done all your vascular imaging and they are okay, and then you have a significant aortic arch atheroma, then you, with a degree of certainty, we can then say that, well, this can be a good enough reason for that person to have embolic looking stroke. So we don't need to go in and hunt for further underlying etiology and maybe avoid some of those investigations. So it's more of how to guide or when to stop. I completely take your point that all you'll be doing probably is giving them statin, but it's more of whether you go and investigate them any further or not.
Yeah. So for your non-diabetics, it's very, very uncommon. You'll find aortic disease with calcification below 60. Okay, so you're talking about your elderly patients with aortic disease, apart from diabetics, and you probably see carotid disease by then. Okay, these are kind of your high-risk patient. I just think that your yield to look for it would be very, very low. You probably have to scan thousands to find one odd one that you say, oh, he's 50-year-old without diabetes, but he's got a lot of aortic arch disease, so I should start statin. But I would say majority of patients would have covered by statins. In terms of the modality for embolic stroke with undetermined source, what I generally do is I basically look at kind of the reverse risk factors for your stroke. If the risk factor for stroke is high, I would normally keep searching for atrial fibrillation. If it's the opposite, like your kind of unconventional stroke, very young patients, no hypertension, no diabetes, and so on, then I will look for the PFO and then kind of try to treat that. So that's kind of my general kind of way of doing it.
Yeah, and is it the bubble echo will be the sort of imaging modality in these cases, isn't it?
Yes. So bubble echo will give you the functional element of the PFO, whether it's actually opens, whether it's actually functionally significant, and then TOE is actually look for the size, whether it's closable. So it's a kind of a second thought, if you like. So you need to know the functional status of the PFO first. Yeah.
Excellent. Thanks so much, Jun.
What
Before going for
one of the
cardiac imaging,
questions to the
sorry, go on. Yeah.
sorry, may I ask any question? May I ask any question? I'm
Yes,
from
yes,
Go ahead.
please
Yeah,
go on.
of course.
Yes, please.
I have a question to my cardiologist that a patient, his engineer, aged 55 years, suffering from recurrent stroke of posterior circulation, and all the modalities of investigation we have done, he is normotensive, non-diabetic, but we have seen in echocardiography, he is suffering from HCM, hypertrophic cardiomyopathy. Is there any evidence or is there any experience to you that HCM can cause a stroke of undetermined origin, particularly the embolic stroke of undetermined origin, HCM, hypertrophic cardiomyopathy? He's only have hypertrophic cardiomyopathy. His echocardiograph says that there's the ejection fraction is very good, good contractility, but he has recurrent stroke, 2 stroke within a year, and nothing happened. He was on antiplatelet for the first time of his undetermined stroke. He has done his echocardiography, transesophageal echography, nothing. But after the second event, we have given anticoagulant, and for the last 3 years, he's having no stroke and he's okay. What is your experience regarding the HCM and embolic stroke of undetermined origin?
Okay. In terms of the HCM, we do worry about kind of thrombosis and embolic events. So, for example, if you've got a young HCM patient with AF, even with CHEST score of low kind of CHEST score, we will anticoagulate them because we know they've got an increased risk. But we don't generally anticoagulate them if we haven't found AF in an HCM patient. So there's definitely an increased risk of embolic event. But would not generally anticoagulate if there's no AF.
That's a very interesting thought because
Can I add something?
Of course,
Yes.
please do.
I have some experience with hypertrophic cardiomyopathy. Patient with most likely apical variety, that is hypertrophic cardiomyopathy of apical variety, they're more prone to atrial fibrillation and they're more prone to embolic stroke, and they do not need any CHEST score to add, and that is the DOAC or NOAC. So they are more likely to have embolic stroke. So they are high risk patient with hypertrophic cardiomyopathy, and they are more likely to prone to develop atrial fibrillation and stroke because it is subclinical. So if you put the device inside the patient, the device can detect the subclinical AF for a few seconds or few hours. For last 3 years data, I have shown that more than, I don't exact number, a lot of patients have that subclinical AF, and ultimately this patient gone to clinical AF. So it is very, very important to patient with hypertrophic cardiomyopathy, most likely apical variety, they have the high tendency to develop embolic stroke. Thank you very much.
Yeah, I totally agree. I mean, they definitely got increased risk of atrial fibrillation. Hence, some clinicians do, out of kind of evidence-free zone, would start them on anticoagulation with HOCM. The other thing I want to touch on, Dr. Rahman, you mentioned about patients with DCM or falling at MI, about LV thrombus and clot. So in general, you only get clot formation in the LV if you got that akinetic region. So i.e. the muscle is not moving. DCM, you don't have normally akinetic regions. You have very, very hypokinetic region, but they move. So you can't have a totally akinetic region. So you have a dead patient basically. So hence, it's normally your MI patients with apical thrombus and a region that's not moving at all. Even if they shake or they twitch, you shouldn't have thrombus. Yeah.
Would you say that in those patients, I mean, looking through some literature about the cardiac MRI, and if they have focal areas of fibrotic changes, would that then make them a higher risk, or would they not have it at all?
No, so you need to have a what we call non-viable region. So it's basically transmural gadolinium, where it is basically akinetic. So it's not moving or dyskinetic. So the wall literally just doesn't even twitch. So the gadolinium kind of just tell you whether it's totally dead or kind of a bit dead. Yeah. So I don't think gadolinium itself kind of helps you, but obviously if it's total transmural, then you are safe to say it's an akinetic region with a thin wall.
But I think I completely agree with both of you that although this is a high risk entity, but I mean there are various trials where it showed that just giving them anticoagulation without evidence of definitive paroxysmal atrial fibrillation, it actually did not end up with a statistically significant benefit in this patient group. Prof. Hussain, may I ask you a question? In terms of investigating paroxysmal atrial fibrillation in Bangladesh, what is the approach that you all do in Bangladesh, and what sort of investigations do you do?
Most likely we do the 12-lead ECG and then 24-hour Holters. Nowadays we are doing 30 for the extended Holter. This is, but it is more costly. But ILR is very costly, so most of them we are doing 7 days Holters. But your lecturer is clearly thought there is no benefit. When in 7 days extended Holter, no benefit. But we do sometimes 15 days and 30 days extended Holter, and one lead Holter. It is available in Bangladesh. We can do it here.
And what's your experience in terms of, as we know that there are more and more devices that they're getting into our patients with ICDs and pacemakers.
When I integrate the device, a lot of patients develop AT and AT designed to atrial fibrillation. So it is transient and sometimes it becomes permanent. So it is the only way the device can determine the subclinical or occult atrial fibrillation. This is possible. When the stroke, okay.
Now, and are you sort of then converting them in to have DOACs if they have a high class?
Yeah.
Great. Thanks.
Can I ask one question to Professor Hussain? Is there any 12-lead ECG criteria to suspect that can be a herald of paroxysmal atrial fibrillation? Because when a patient comes to us, the acute ischemic stroke, first thing we usually do imaging and then ECG. These are the primary things we usually do. Is there anything we can suspect from 12-lead ECG?
In Bangladesh, perspective, patients who have mitral stenosis. So if you see the 12-lead ECG mitrally, then we can suspect the patient have atrial fibrillation. Otherwise, it is very difficult. Patient hypertension, but otherwise it is very difficult to identify by 12-lead ECG. The patient may have developed atrial fibrillation.
May I give comments?
Yes, please.
Yeah. Till now, we don't discuss about the rheumatic heart disease involvement in the embolic stroke. Acute rheumatic fever due to the rheumatic visitations, rheumatic valvular disease due to the thrombus, and the infective endocarditis for their visitations. These are all the stages of the rheumatic heart disease. There is a chance of embolic stroke, and it is not uncommon in Bangladesh. Though incidence of the rheumatic fever has gone down remarkably, but still There are many patients with the rheumatic heart disease. Sometimes these are not recognized the rheumatic mitral stenosis, and the patient may sometimes present with the features of the stroke, embolic stroke. So it should be, we should keep in mind that the rheumatic heart disease is the very good common cause of the embolic stroke in Bangladesh, so far as cardiologists are concerned. And another thing I can put it here, that the LA function, determination of the LA function may give us some clue to the embolic stroke, origin of the embolic stroke in the LA, without the development of the atrial fibrillation. The number of the papers have been published recently, that particularly by the strain, if we do the strain, then there is some LA dysfunction, and that may be the harbinger of the thrombus that may lead to the embolic stroke.
You're spot on,
That's
Prof.
quite
Majumdar. I think
interesting. Yeah.
atrial substrate is a thing that's coming up, isn't it, June? What's your experience with this? Do we actually do functional imaging and studies to look for those changes in the atrium or the atrial substrate?
So not routinely.
It is not a routine practice for the LA functional assessment, and we have one or two in the whole country. We have one or two machines that can have the strain of the LA. So it is not routinely practiced till now, but it is a very promising, I think, promising way of identifying the harbinger of the embolic stroke.
Yeah, I agree. I mean, certainly it's not routinely done for atrial strain, but we can do that, and we know that there's evidence that it does predispose you to atrial fibrillation. I think routinely the only thing that we do is the LA volume, that's to help us to know whether there's atrial fibrillation. The other thing that we do kind of routinely in terms of as a side thing is gadolinium enhancement with the left atrium or the right atrium. So because we are doing the late GAD anyway, we can see it. And we know that the EP, electrophysiologists for ablation, they do look for the scar. Yeah.
Perfect. Prof. Alam, may I ask you a question in terms of young stroke population in Bangladesh? So like in UK or in Western countries, we'll be looking at things like thrombophilias, antiphospholipid syndromes. What sort of underlying etiology do you come across in your young stroke patients in Bangladesh?
Thank you for your question. Really, the young stroke, we are evaluated, particularly the evaluation done for cardiac telemetry. Firstly, cardiac telemetry we do, then we do thrombophilia screening, and we also do the antiphospholipid antibody. And in our perspective, we do sometimes CSF study, and one of our from embolic stroke of young stroke, and that patient, we have done the CSF study. In spite of all the study done, after that we have done CSF, and CSF shows TPHA and VDRL was positive, and that patient was diagnosed as a case of syphilitic aortitis lately, and finally we have concluded the diagnosis that the patient is suffering from Leutic disease. So sometimes we do the CSF study also, and practically you have done a question that in cardiac telemetry we do only the 12 lead ECG, and also the echocardiography, and also the 24 hours Holter, and sometimes we do the 7 days Holter, nothing. So this is the limitations in our country, but we do the diabetic and lipid profile, and we do the cardiac, and also we do the CTA of the brain and neck vessels, MRA of the brain and neck vessels, and these are the tests we do for the young stroke of our patient. But we could not find sometimes no identified cause, particularly 50 to 25% of the patient we did not find any definable cause.
One of the things that recently came to my notice is antiphospholipid syndrome, which are seronegative. And this has really become a big entity now. And it's about 5 to 10% of cases where you have phenotypically quite strong suspicion that the patient may have antiphospholipid syndrome, but you've done repeated antibody testing and they're all negative. And partly because the antibodies that we were testing routine, or what we are doing routinely, is IgGs and IgMs. And some of these patients actually can have IgA antiphospholipid antibodies, which are the culprit in these cases. And there are a lot of other non-criteria antibodies that has been identified. And now the go-to approach is that if you have a high suspicion, clinical suspicion of antiphospholipid syndrome, these patients get sent to a tertiary center where they have the non-criteria antibody testing. And then eventually about 5% of cases they turn out to be diagnosed with seronegative antiphospholipid syndrome, and they went on to have warfarin for secondary prevention. I'm not too sure whether this is something that you come across in Bangladesh.
Thank you for your expert opinion. Thank you.
Thank you so much. Nadia, is there any other question on the chat box?
No, there is no other question. I have one question to Dr. Sanpardi, just out of my curiosity. Is there any difference of radiological pattern in case of embolus arising from large vessel atheroma and embolus arising from heart? Can we differentiate it by looking at imaging?
It's not as easy as at all times, I can say. It depends where the aortic atheroma is located. I mean, might be a clue for a radiologist. Let's say there is one hemispheric involvement and the atheroma is involving the origin of the ipsilateral carotid artery origin, for example. So in this case, you might make your assumption, but if it is not straightforward at all times. So you might, I mean, I don't want to say something wrong in front of the cardiologist indeed, but maybe in terms of the distribution, the source of the embolism, aorta is not significantly different than the left heart to me. So, because it is sort of bridging between. Regarding the origin of the four main vessels, including brachiocephalic artery, let's say free. So it is quite similar, but in some exceptional cases, as I told you, atheroma involving a particular side of the aorta, if the embolic shower is in the same side, so in these cases it might be relevant. Otherwise, it's not easy at all times. Yeah.
Maybe that's an interesting question, Nadia, because anything below the arch has the potential to go anyway. So it can go into the carotid circulation, it can go into the vertebrobasilar circulation. So something that's arising from the heart can navigate its way into any of these vessels, and then can cause either anterior circulation or posterior circulation infarcts, or at times it can be multiple vascular territory involvement at the same time. At times when you see that there is a posterior circulation stroke, but there's no vertebrobasilar stenosis, but looking through the images, you could see that there's actually a subclavian stenosis or atherosclerosis just before the origin of the vertebral artery. And that is the source of the emboli that has navigated through the vertebral artery. So I think the take-home message probably is to look at your patient, look at the images. If something doesn't make sense, then you go back and revisit the images and have a second look, because a lot of time that may give you the answer. Thank you very much. Thank you all for attending today, and it's exhilarating talk and discussion, and I'm grateful to all of you. Thank you.
Thank you.
Thank you.
Thank you very much for joining
Thank
us
you.
today.
Thank
Thank
you,
you very
everybody.
much.
Thank you very much.
Thank you.
Bye, everyone.
Yeah, sure.